I'm going to ask this during my talk to those who do not listen to me, just like at medical school. So please listen to me. It's extremely important. Thank you. So these are my disclosures, and you have seen that already. Paul explained to you the difference in metabolism between the three drugs, 2p2I12 inhibitors, Clopidogrel, TRITON, and Ticagrelor, and the result of the difference in the metabolism of the drugs is here. With prasugrel, there is a much faster onset of action and a much higher and more consistent level of inhibition of platelet aggregation. And much the same with Ticagrelor. It was explored in a dispersed 2 sub-study, showing exactly the same. There was much faster onset of action, much higher level of platelet inhibition. So now we go to the clinical results. Let's start with TRITON TIMI-38. This was a trial I constantly use this trick at medical school, and all of a sudden the audience becomes silent. And if you keep silent till the end of my talk, promise I will tell you a very nice, decent joke at the end of my talk. Not now, at the end. So TRITON TIMI-38. This was not a trial in the setting of acute coronary syndrome. 13,000 patients with ST elevation myocardial infarction or non-ST elevation acute coronary syndrome. But it was not a trial in the setting of acute coronary syndromes. This was a trial of percutaneous coronary interventions in the setting of acute coronary syndrome. And this makes a big deal of difference. And what you have to understand is that in this trial, only Clopidogrel naive patients could be included. So you perceive immediately that the indications, the labeling of the drug will be confined to a niche. In other words, Clopidogrel naive patients taken to the cath lab with known anatomy and percutaneous coronary intervention. It's a niche indication. I suspect that the design of the trial was conceived according to the US habits for PCI in the setting of acute coronary syndromes. So I'm not going to show you the results. Paul Goebel showed you the result, and anyway you know them. There was roughly 20% risk reduction for decima and stroke, and the price to pay was a 25% or so increase in major non-CABG major bleeding. Now, PLATO. PLATO is completely different. It's 18,000 patients with acute coronary syndromes, all comers, ST elevation, non-ST elevation, medical treatment, PCI, surgery, etc. Clopidogrel and Ticagrelor, no need to go into the details of the dosing. And the other big difference, as regards compared to TRITON, is this. Roughly 50% of the patients received Clopidogrel before randomization. So it was not an exclusion criteria. And again, you can immediately see the difference in labeling between the two drugs. So you can do whatever you like with the labeling. You can give, for example, prasugrel before the cath lab, take the patient to the cath lab, and then do the job, but you are off-label. You may not care. But in case something goes wrong, for example, intracranial hemorrhage, never forget, I don't know for Israel, I know for the US, there are many more lawyers in the US than there are doctors. Agree, Joe? Paul, you agree. So pay attention to labeling of the drug before deciding to go off-label. Now, let's look at really serious matters. The other big differences between the two trials are here. About a third of the patients were suffering from STEMI in PLATO, and only roughly 25% in TRITON, with 8% late comers. This is one of the big difference, and also a big difference in terms of troponin release. 20% difference between the two trials. This has an impact on the severity of the disease and the outcome. And here, the intervention. By design, 100% of the patients were taken to the cath lab, but only a minority were not submitted to PCI. And very, very rare CABG surgery, only for those in whom PCI failed or was complicated. Very few. In PLATO, about 60% of the patients went for PCI, 5 to 6% for CABG, and a third of the patients had medical treatment. You know the results already. And what is remarkable in PLATO is that the risk reduction here is a risk reduction for the whole group, the whole trial, 16% risk reduction for the composite primary endpoint, death, myocardial infarction, and stroke. And you can look at every single subset of patients, the same risk reduction. Now, apparently there is no group that derives a better benefit, but on the other way around, what did I say just now? The lady with the red shirt. Hello, I'm talking to you. I'm talking to you. What did I say? So, there is not a single group that does not derive a benefit except the US. US patients included in the trial didn't derive a benefit, and we don't know the explanation, but we know that there was an interaction between Ticagrelor and high-dose aspirin. Now, I said this morning in a debate that I have an interest in hard endpoints, robust studies, and here is more than robust, because there is 16%, you can consider any kind of primary, secondary objective, roughly 16% risk reduction with Ticagrelor compared to Clopidogrel. But look here, bingo, there is a huge risk reduction for cardiovascular death and a risk reduction for all-cause mortality. And it's not trivial, it's more than 1%. It's a major risk reduction in terms of death. So it's definitely a robust endpoint, so we can be sure that this is definitely a major outcome in this trial. Myocardial infarction were relatively less, the risk reduction was less important, 16% compared to cardiovascular death. Might simply be due to the definition of infarction. And bingo again, no difference in overall rate of bleeding overall. But if you look in the details, it's quite clear that if you consider non-CABG TIMI major bleeding according to TIMI definition, then the rate is virtually the same as in TRITON, with a 25% or so increase with Ticagrelor. What does this mean? It simply means that long-term exposure to a very potent antiplatelet agent increases the risk of bleeding. Because the difference in the risk of bleeding is not during PCI, it's the same in both trials, but long-term. And of course there is a price to pay. There are some side effects. You know that the drug as an interacts with heart rhythm, and particularly we observe more frequent ventricular pauses over 3 seconds. But if you look at the gross picture at the bottom of this slide, there was no more pacemaker insertion, a trend towards more syncopes with Ticagrelor, but roughly no difference in major endpoints, side effects. Other findings, this may still more or less unexplained. We are talking about excess of adenosine and interaction with purine receptors, but the truth is that this may, in spite of the fact that it's quite common, leads very rarely to discontinuation of the drug and vanishes after a few weeks of treatment. And no neoplasm during the course of treatment. This is what has been observed in TRITON. So let's see a few subgroups and PLATO invasive strategy. Quite a few patients, 13,000 plus patients were submitted to some sort of invasive strategy. Roughly all invasive procedures were carried out during the index hospitalization. PCI 76%, 77%. In the setting of unstable angina, non-S elevation myocardial infarction, a third of the patients, STEMI much more frequently, of course, is primary PCI, and CABG in the range of 6%, quite significant number. Do you want to see the results? It's just copy and paced. Exactly the same. The risk reduction is 16% overall for the cardiovascular death, MI, or stroke. And again, bingo, risk reduction for cardiovascular death and total death. Quite important. Same risk reduction, well, more important risk reduction for myocardial infarction and again cardiovascular death. Of interest for the interventional cardiologist, there is a 38% risk reduction for stent thrombosis, definite stent thrombosis, which is again very impressive. And if we look in the details, I don't have more data than that. If you compare STEMI versus non-ST elevation myocardial infarction, then there is a much higher efficacy in the setting of non-ST elevation acute coronary syndromes, 17 versus 14% risk reduction, and you may appreciate that non-ST elevation acute coronary syndrome have a much worse outcome than STEMI at 1 year. And again, significant risk reduction in troponin positive patients, in other words, non-STEMI patients, but zero effect whatsoever in the setting of unstable angina. Non-invasive strategy, we have to address this issue because 35% of the patients had non-invasive management, and here again is absolutely impressive. I'm just concentrating on one endpoint, the most important of all-cause mortality. And here there is 25% risk reduction for death in medically managed patients. And you may appreciate again that they have a much worse outcome than those who are submitted to invasive management, mean that the baseline characteristics of these patients are much worse than for the others. CABG. CABG, this is a big surprise. CABG, you have to understand that's a post hoc analysis, not pre-specified group. And unexpectedly, there was a huge risk reduction for death in patients who were submitted to CABG in PLATO. Basically, twice as lower risk of death with Ticagrelor compared to Clopidogrel. And, well, this is a fact, might be due to chance, but in TRITON, it's exactly the same figures, with much less patients, only 1% of the patients were taken to the operating room in TRITON. The very bizarre fact is this, because if you look, you know, those patients taken in a CABG subgroup analysis had to be operated on within 7 days after discontinuation of the drug. And if you look at the difference in death rate according to when the drug was stopped, there is a huge difference between Clopidogrel and Ticagrelor. It is unexplained. We cannot rule out the fact that some patients might have been taken to the operating room very early after its initial phase, and some other quite late, which might explain the difference in outcomes during the first 3 or 4 days. But more or less it remains unexplained. What is sure is that there was no difference in bleeding between the two groups, and the difference in bleeding cannot explain the risk of reduction for death in Ticagrelor group. Renal dysfunction. 20% of the patients had creatinine clearance lower than 60 milliliters per minute. It means moderate, at least moderate renal dysfunction. And look at this, check it out. This is primary endpoint, death, stroke, or MI. The difference is not statistically significant for normal renal function, but there is a stepwise increase in the improvement in the outcome depending with decreasing creatinine clearance, which is absolutely impressive as well. And if we concentrate again on the major endpoint, all-cause mortality, again there is a significant risk reduction, 28% risk reduction for death. And we all know that renal failure patients are at much higher risk than the others, and the best of my knowledge is the first time that we report on such impressive risk reduction for death with a drug compared to another in this setting. Diabetes is more or less copy and paste. Diabetes, of course, have a much higher risk than the others, and again, there is a significant risk reduction for death here, 18%, hardly significant, but still same message, same magnitude of risk reduction in diabetic patients. Now, please stop talking to each other. You may forget everything that Paul has told you. You may forget everything I told you so far. The important message is now. So please look at the message. These are the recommendations, the latest version of non-ST elevation acute coronary syndrome guidelines for Ticagrelor. And Ticagrelor, due to the outcome observed in PLATO, is recommended class 1, level B, because there is only one trial, and is recommended for all patients, irrespective of the management strategy, medical, CABG, or PCI, at moderate to high risk of ischemic events, particularly elevated troponins, regardless of initial treatment strategy, and including those pre-treated with Clopidogrel, which should be discontinued when Ticagrelor is started. In other words, you can give the drug irrespective of the clinical setting, with, without ST elevation, etc. Prasugrel. People ask, hey, why don't you recommend Prasugrel more than that? We have, when you write guidelines, you do not guess. You have to stick to the design of the trial. So the 1B level recommendation, same, but Prasugrel is recommended for P2Y12 inhibitor naive patients, particularly diabetics, in whom coronary anatomy is known and who are proceeding to PCI unless, etc., there is an excess risk of bleeding. We just confine Prasugrel to the niche in which it was developed, and that's it. Does this mean that Clopidogrel is dead? Of course not. And Clopidogrel is considered in the guidelines, and we just say, if Ticagrelor or Prasugrel are not available, you have to go for Clopidogrel for any reason. And don't forget that with Clopidogrel, a new trial has determined that a higher dose, 600 milligram loading dose followed by 150 for a week, derives a better benefit, leads to a better benefit for the PCI patients, only 17,000 patients in current.